Hi. Hello, good morning, everyone. Today I will speak, as Nasser said, about a subject that for me is very dear. And in the following slides, I hope you'll have a very nice journey with me in the world of ultrasound with contrast. So the agenda for today is I will talk a bit about the ultrasound contrast agent and the principle of contrast ultrasound, and the applicability of contrast enhancement ultrasound in non-interventional part of the ultrasound and interventional. What is the what is the sonoview? Because about this contrast I will speak more. It is a low solubility gas that is used to enhance the echogenicity of the blood. And because we use a low mechanical index, we don't see anymore the tissue. The tissue is decreasing in intensity, and we see much more the vessel. The size of the sonoview bubbles is 2 or 6 micromillimeters. And what is very important for us to know is that the sonoview, it's a blood pool agent and doesn't cross the membranes to enter in the extracellular space. Liver, you know, that has a dual vascularization. This is a very important point because due to dual vascularization, we will have 3 phases of the contrast. The arterial phase, where the contrast comes via the hepatic artery, and will give us information about the pattern of the arterial vascularization. And this helps us to differentiate the benign lesions. And the portal and late phase, that is the most important phase to establish the nature of the lesions. Why? Because the malignant lesions do not have portal vessels. So here in the portal and the late phase, we can make the differentiation between benign and malignant lesions. Are several available contrast agents, but we use only sonoview. And based on the behavior, we can, as I told you, we split the lesions in malignant and benign, and according with the arterial phase that I have to mention is very important. Only for benign lesions, we can differentiate the benign lesions in different subtypes. For what the Society of Ultrasound in Medicine and Biology recommends the contrast when we have an incidental finding of a lesion in the B mode. In the case we have inconclusive findings in CT or MRI, or when the cytology and histology doesn't help us, and or as the first contrast imaging modality in patients with renal insufficiency, or when the CT and MRI are contraindicated. However, we should bear in our mind that if the lesion is very deep or the liver is very fat, contrast enhancement doesn't bring too many information. So now we have a hemangioma. I'll start to show you a bit about the different lesions. And this is the lesion. We administrate contrast. What is very important to know, in the hemangioma, we have a peripheral nodular contrast enhancement that will have a progressive enhancement in the centripetal direction. This means towards the centrum. And in the late phase, the lesion is completely filled with contrast. Of course, as always in medicine, we have also typical hemangiomas. And for me, this is the hemangioma that we have to bear in mind. It is with arteriovenous shunts. It's a high flow hemangioma. In this hemangioma, we'll have a very rapid hyper enhancement, and sometimes we can have a slightly washout. And here comes the main differential diagnosis with the metastasis. Thrombose hemangioma also can put us problems, we don't have an enhancement, and we can have also differential diagnosis with the necrosis of the malignant lesions. Focal nodular hyperplasia, I think, is one of the most beautiful lesions. We have a rapid filling from the center to the outside. It's a centrifugal enhancement. However, an exception when we can have an multi-locular arterial supply or eccentric feeding. And in the late phase, 93% of them are iso-enhanced, but we can have also in 6.5% of them and slightly hypo-enhancement. And as I told you, the malignant lesions are doing a washout. So here comes the main differential diagnosis with the malignant lesions. But however, this feeling from the center to outside helps us to put the diagnosis of FNH. What we have to know is that the accuracy of contrast enhancement ultrasound, it's a matter of size, and the accuracy is decreasing for lesions more than 3 centimeters. Inflammatory or adenoma, but this is a case of inflammatory adenoma. It is a centripetal contrast enhancement. What means this is from the periphery to the center. What is typical for this type of adenoma, it is an peripheral rim sustained enhancement with an hypoechoic central area. Portal vein thrombosis here. It's a it's a case of a young guy. As I told you, the malignant lesion have arterial vessels. So here is the portal vein. In the arterial phase, we'll have already contrast in the venous, in the portal vein, where is the thrombus, followed by washout. Okay, in the blend portal thrombosis, as expected, the thrombus has no vessels, so then we'll have no enhancement. What we know that the contrast enhancement ultrasound has a sensitivity depending also by the operator between 88–97.7% and a very high specificity. Of course, we can have also false positive behavior towards malignant thrombus when we have a granulomatous infiltration of the portal vein thrombosis. However, contrast enhancement ultrasound is recommended to make the differentiation between benign and malignant portal vein thrombosis. What about the malignant liver lesions? Here, arterial phase is not specific, so we should not insist very much when we perform an ultrasound on this phase, because we can have hypervascularity, rim enhancement, can be also hypovascular, depending on the quantity of the fibrosis and the type of the tumor. But what I consider that is the most important is to know that we don't have portal vessels. I insist with this. So we'll have a very early washout within 120, mostly 60 seconds after the contrast injection. And when it's useful contrast, mostly in the metastases that are below 1 centimeter, when you know that CT and MRI don't bring too much information. Okay, here it's a case of a patient with pancreas carcinoma. Here we have a small lesion, you see here, and you will have an iso enhancement. Slowly. Here is the lesion. Here, you see, the lesion takes the contrast. We don't see any hole. Followed after 2 minutes of a washout, slightly washout that is accentuated. Okay, what is important for the ACC, because I said it's important in the malignant lesion, it's a washout within 2 minutes. In the hepatocellular carcinoma, at the beginning has artery and portal vessels. And portal vessels are disappearing in time. In time, what means when the lesion is poorly differentiated, we won't have any more portal vessels. Also, the hepatocellular carcinoma is losing the portal vessels when it is increasing in size. So what do I want to say with this? I want to say that when the ACC is very small, or when it's well differentiated, we won't have a fast washout. So the washout is after 4 or 5 minutes. This is why it's very important when we when we perform the ultrasound, not to stay with the ultrasound sound too long, not to produce a false, to distract the bubbles. Okay, so this is a patient who was non-cirrhotic, came to us because he found, the house has found a lesion. And what do you notice here? Second is coming. We are very a lot of vessels, and you see here we have a hyper enhancement. At the beginning, the patient was with a big lesion, had a necrotic area. At the beginning, this necrotic area was of 2.6 centimeters, but you see that at the end, after 6 minutes, we have a clear washout of this part that was enhancing. And indeed, in the biopsy, it was also on HTT. Cholangiocarcinoma tumor, it is also, we can have 3 types. Mass, like a mass-like, infiltrative, or intraductal. Cholangiocarcinoma, it is a lesion that has a lot of fibrosis. This is an important point. Why? And it's washing very fast, comparing with ACC. Why it's important? Oh, sorry, I think I don't have a movie here. Because after the administration of the contrast, the lesion is hyper enhanced, but as I told you, it's very important the time of washout starts to wash very fast, and you see central that is accentuated, and in 4 minutes we have in the periphery still a bit slowly, if you have a bit of imagination, hyper enhancement, but central is hypo enhancement, is the washout. This patient, it was an old lady. We perform a biopsy because we have to perform biopsy. Contrast enhancement is not considered a good method to make the differentiation between cholangiocarcinoma and ACC, proved to be an cholangiocarcinoma. So contrast enhancement ultrasound is recommended also to in the detection, in the diagnosis of malignant lesions. But I have here a slide with the comparison between ultrasound with contrast and CT and MRI. You can see that contrast is scoring quite high, and why? It's a strict intravascular contrast agent and allows us also in the real-time visualization of the pattern. It has less anaphylactoid reaction, is cheaper, and has a good sensitivity and specificity. But now about contrast enhancement in interventional ultrasound. So, post-TAE, again, we have also, it's used to detect the residual tumor. And here sometimes contrast scores a bit higher than MRE and CT in the beginning, in the first month. What is very important is to know that can exist a slight inflammatory area post-TAE. But in this case, we can have a slightly washout, but the washout is not very pronounced. This was a patient that had an TAE, and we perform a contrast. We said that it is a rest of the tumor. It was performed after that an MRI, and then MRI confirmed this. So why we should, do you know, everyone who is performing done biopsy knows that during the biopsy we have some challenging situation. What should we do if we don't see the lesion? And the recommendation is biopsy only if you can see the lesion. And what to do? Make it visible. But we have a big tumor. How can we know where are the viable parts of the tumor, where it's not necrotic? Make it visible, the viable parts. And if we have a cystic lesion, or a complex lesion, which part should be biopsied? The tumoral one or the lesion that has vessels. And now we have a patient with a tumor of the pancreas, and you see, we don't see, are some isoechogenic lesions. And I think I don't have the, sorry, here. We administered contrast. The images are from my former professor and mentor in the contrast. Here, I will explain later. You see the needle, and the biopsy was performed from the lesion here. Yes, I now go back here. Sorry. Here is a big lesion. In fact, it's an ACC with the invasion of the portal branch. Here you cannot know where to enter. You are happy, you have a huge lesion. Yes, I will biopsy, and you biopsy. If you don't see what you biopsy and you don't know where to go with the needle, you will have in 1 week, the lesion was necrotic. So you see only the periphery had viable parts. So it's very important to know where you go. After we performed contrast in my former clinic, we understood that in general, you have to biopsy the periphery of the lesion because there all the time is viable tissue. Okay, and here it's a study where I participated. The overall sensitivity, accuracy for the contrast enhancement guided biopsy was 96%, comparing with 81 in with B-mode guided biopsy. But it's also very important. It was 3 years ago was another study that they showed that if we use in these problematic lesions the contrast enhancement guiding biopsy, we need a single puncture, not more puncture. We don't have to enter 2-3 times. So in this way, we have also a decreased risk for complication. Okay, of course, here are the guidelines that recommend the contrast to avoid the necrotic areas, to identify the target lesions. Okay, what is important for you to know that are 2 types of contrast ultrasound guided biopsy. For all, we can do this in 2 steps. We perform contrast, and after that, the biopsy guided with B-mode ultrasound. We do this here, all 1 step. We perform the biopsy during the contrast. However, this is very complicated because we have to know when in arterial on the portal phase, late phase, because you know that with using non-stop the sound, you distract the bubbles. So it has to be, the process has to be super fast, and you have to perform the biopsy within 1 minute. And this why is mostly we use in the portal phase. What is needed to know that you need to have a very good experience in performing ultrasound, and sometimes it's very difficult if the lesions are very deep or small. Okay, and now it's about something that we don't use here, but I use in my former hospital, intracavitary administration of the Sonoview. It's used to emphasize the connection between two cavities, a fistula, pleuro-peritoneal communication, or an abscess with an biliary duct. In this case, the quantity of the contrast has to be higher, this 1 to 2 milliliters. But if we want just to delineate the cavity of the collection of the abscess, we use 2-3 drops of Sonovium in 100 milliliters NaCl. How is administered? Via a drainage, and we use to evaluate the residual cavities after resection, to evaluate a liver abscess, to see communication with neighboring structures or anatomical details of the abscess. So here we have an abscess. You see, this is the necrotic area that can be punctured. I don't know. Here will be the puncture of the, I have to say that in Romania, I know it's different by here, but we do this guided with the ultrasound. And here you see the catheter, okay? And the same, here is a complex abscess. We know exactly where to enter. And here it's after we introduce the catheter, we check if it's correct placed. Okay, here is the intracavitary contrast. Here is a phlegmona. Again, it's super important because we see exactly where we should enter. And here we have an abscess. We drained, and after the drainage, we introduce the contrast, and you see it's a communication with biliary ducts. We perform a cystography that confirmed this. Here we have an cyst, an abscess that was drained, and with the contrast, we see exactly doesn't have any communication with any biliary ducts. Okay, so it is recommended to be used to delineate the liver abscess and to identify for the identification of the correct drain position. Can be also used in transhepatic biliary interventions, but due to the lack of time, I didn't discuss this part. However, you have to know that we are limitation and it's very operator dependent. The quality of contrast enhancement ultrasound is dependent on the quality of the B-mode ultrasound. And don't perform contrast enhancement ultrasound for very deep located also diaphragmatic lesions or very, very small, because we don't obtain relevant information. And in the steatotic liver, contrast enhancement ultrasound has a reduced sensitivity and specificity. Okay, thank you very much for your attention, and don't forget, use the right bubbles.
Sehr schön, vielen Dank, Pompilia, für diese Präsentation. Es gibt sicherlich Fragen. Vielleicht fange ich mal mit einer an, und zwar, also ich persönlich, wir setzen das ja bei uns alle ein, und ich bin ja auch ein großer Fan vom Kontrastmittel Ultraschall. Was ja manchmal schwierig ist, hattest du ja auch gezeigt, wenn es darum geht, im Kontrastmittel Ultraschall zwischen einem hepatozellulären Karzinom und einem cholangiozellulären Karzinom zu unterscheiden. Kannst du da vielleicht noch mal kurz darauf eingehen? Also, wenn ich das so richtig verstanden habe, so, dann hat er so einen Hint oder so eine Idee, quasi beim Washout, also das...
Ja.
Oder? Kannst du dazu noch mal was sagen für die Kollegen, die das so noch nicht kennen? Also dass das zum Beispiel länger braucht, sage ich jetzt
Okay,
mal,
so
anscheinend beim longitudinären Karzinom und bei dem HCC vielleicht schon früher das Washout kommt.
so as I told you, maybe I go here at this image because this image for me is fantastic. As I told you, in the difference is that the hepatocellular carcinoma maintains some portal vessels, has some portal vessels, very, very late not. And this why the washout is in general, and is super important, is after 4 minutes. Never ever expect an hepatocellular carcinoma to wash in 2 minutes. So an ultrasound examination with contrast has to be performed correctly until 5 minutes. Because if it's an hepatocellular carcinoma and you are at 4 minutes, after 3 minutes say, oh, didn't have any washout, then you might miss an hepatocellular carcinoma. In cholangiocarcinoma, we have a lot of fibrosis that is mainly in the center. This explains why we have, it's not super enhanced in central, comparing with the ACC. So we have an uptake of the contrast, but it is a slightly less enhanced and is faster washout. And in the periphery, it remains enhanced. Also, it's an edema. It's a bit more complex. So there remains hyper enhanced. We have like a ring all the time in cholangiocarcinoma, and a fast washout. This is faster, much faster.
Okay. Hat sonst noch jemand eine Frage, einen Kommentar dazu? Also vielleicht kann man ja noch erwähnen, also das, was wir ja auch tagtäglich einsetzen bei unseren Patienten mit einem hepatozellulären Karzinom, mit einer lokal ablativen Therapie, sei es Mikrowellenablation oder eine TAE. Das ist auch das Schöne, bis vor einigen Jahren war es ja immer so, dass man ja eigentlich immer eine Computertomographie oder das MRI gemacht hat. Allerdings hat man das immer frühestens 4 Wochen nach so einem Eingriff gemacht. Vorher wäre das immer so ein bisschen schwieriger zu beurteilen. Also man weiß ja bei CT oder das MRI, dass es natürlich so falsch positive Resultate zeigen könnte, wenn es darum geht, um die Frage nach einer Restaktivität nach so einem Eingriff. Und das hat man ja, das Schöne beim Kontrastmittelultraschall nicht. Deswegen kann man da nämlich schon früher quasi die Verlaufskontrolle oder den Erfolg kontrollieren. Und das ist der Unterschied wegen des Kontrastmittels, also eben mit dem Sonovue, dass das ja wirklich nur in den Gefäßen bleibt. Das hast du auch so erwähnt, wobei die Kontrastmittel jetzt beim CT oder das MRI kann natürlich auch so diffus auch ins Gewebe gehen. Und das ist ja so typisch nach so einer Mikrowellenablation oder einer Embolisation, dass es natürlich so eine Art Hyperinflammation im Gewebe gibt. Und das täuscht dann natürlich oder täuscht vor, als ob das natürlich noch eine Restaktivität sei. Und das ist, finde ich, natürlich so ein zusätzlicher Vorteil beim Kontrastmittelultraschall.
Darf ich noch schnell was fragen dazu? Was ist denn der beste Zeitpunkt nach der Embolisation? Wir machen das ja standardmäßig 3 Wochen. Aber kann man das rein theoretisch auch früher machen? Oder?
Yeah, there are studies that says that after one week you can do, but as I said, sometimes until 5 days it is this inflammation after and then you can have a problem with this inflammatory peripheric rim, can mimic an rest of the ACC. Of course, in the literature, they say that if it's an inflammatory, it's homogeneous enhancement, but in the reality, it's super difficult to make the differential diagnosis. Because also in inflammation, can be small thrombosis in the vessels and can be also on washout. So it's difficult.
Ich habe noch eine Frage für die Ablation. Wir machen ja die CT-Validierung natürlich nicht, um die Restaktivität zu beurteilen, sondern letztendlich messen wir ja volumetrisch, ob die Ablationszone mit genügend Sicherheitsabstand den Tumor abdeckt und gucken eigentlich nicht nach Aktivität, weil man natürlich dieses Hyper-Enhancement sieht. Aber in den wenigen Fällen, wo wir dann doch mal abladieren, ultraschallgesteuert abladieren, also manchmal ja intraoperativ,
Yeah,
haben wir ja keine Validierung. Also sprich, wie schnell danach kann man wirklich schauen, ohne jetzt die OP-Zeit massiv zu verlängern, ob man den Tumor erwischt hat.
So we in Romania, because I speak from Romania, where we do guide it with the ultrasound, the microwave ablation. The problem is we perform the microwave ablation. It is it's produced a gas that is hyperechoic, and it's very difficult to see the lesion after you administrate contrast. This is why we wait for 10 minutes, the gas is disappearing, and after that we inject the contrast. So, and then we see it is an arrest of activity or not, but we wait all the time, like 10 minutes, and after that we inject.
Gut, dann bestellen wir dich in den OP das nächste Mal.
Yes, exactly. Annalisa, sorry.
Yeah, thanks, Pompilia. Just wanted to ask you if you have some experience or some insight in the quantification of contrast, because there are softwares that allow it.
I know.
I think this would be a way probably to reduce the variability, the inter-observer variability.
It's true. This is true, but I don't have, because here we don't do, and we don't have the software. Maybe we'll take it, but no, just a bit of
only, the problem is a software for research. We do have it also here. It's quite complicated and not used usually.
I have it's minimal. It's minimal. I just know that it exists and how it functions.
Thanks.
Okay.
Sorry, just one quick question, Pompilia. It's sort of similar to, I guess, what Annalisa asked. Do you know if there's any incentive or projects going on where they try and involve AI in things like, very subjective
of course
treatment
options
like
ultrasound? It are. I hope not to have to gather good results and we to remain with the contrast, but they are trying to do also.
Gut, wenn keine weiteren Fragen sind, Pompilia, nochmal herzlichen Dank für diese sehr schöne.
Auch, danke vielmals.
Und wünsche allen einen schönen Tag.